Chairpersons for your kind words. Thank you, Dr. Vijayakumar, for giving me very off the beat topic. I had to spend at least always giving you off the beat topic, and it makes me scratch my grey matter, get back to the books of physiology. I don't know. You will come to know at the end of the lecture, but it is true. So once again, thank you very much. And can you make the slide more presentation? Okay, so topic given to me is the diabetic neuropathy from brain to bowels. And I am showing the cartoon. What is your gut feeling? Now, many times when we buy a mobile phone or we buy a car, we buy it just because we have that gut feeling. We feel that this is the right, despite the fact that we have not studied it very carefully. And also sometimes you've been called to speak at some meeting, or you've been called to speak at the reunion. At that time, suddenly you're called back to speak on the stage. You get butterflies in the stomach. So this butterfly in the stomach and the gut feeling is because of what? Is because the gut is giving some signal to the brain. How it is possible? It is a very unique thing that the entire gut, right from the esophagus right up to the rectum, has the neurons which are there, which are highly dense. Up to 15 million neurons are there in this area, exactly like brain. And they also have structure and function which is very similar to that what you see in the brain. And therefore, the entire gut is called second brain. So this second brain gives signal to the first brain, and they communicate with each other. And that's exactly what D. Vijayakumar wants me to speak, from brain to bowel. So therefore, this is what the Hippocrates says. He was the father of medicine, that all disease begin in the gut, and that's really true. And therefore, to begin this subject, I feel that patients of diabetic peripheral neuropathy, which is 30% in general of your patients of diabetes, have the involvement of the peripheral system and also central system. Its involvement is there. And therefore, the autonomic nervous system concurrently occurs with peripheral neuropathy, though not much discussed about. We don't discuss this very often, though it is always there with your patients of peripheral neuropathy. The concept of teaching is that if you treat a hyperglycemia, your improvement of neuropathy should occur, but that does not occur. So there's something else which is preventing. Could be the central factor is therefore there, which is not allowing you to control your neuropathy despite the fact you control sugar very well. And this involvement of the entire GI tract is known as gastroenteropathy, which is a big entity now, and people have been diagnosing. It is to the tune of 53 to 55%. And therefore, now we have located that insular is the area in the brain which represents the GI system. Therefore, when you have vomiting or your diarrhea, the insular area in the brain is the one which shows signals when you look at the provoked EEG changes in these patients. So traditionally, we have seen neuropathy is diagnosed when you have peripheral nerve dysfunction without any other cause other than diabetes is what is being diagnosed in traditionally. But we know that about 30% of patients do have neuropathy, and 50% of the patients have neuropathy after the age of 50 years. The brain changes are described, and these are because of the afferent activity and the adaptive shrinkage of the brain. And therefore, it is believed that it is because of the peripheral action, but now we feel it could be also primarily a central action of the brain which is responsible for the neuropathy that you see in your patient. This is how you classify neuropathies. I think I will not go in details because this is diffuse, monotherapy, radiculopathy, and so on and so forth. But we're going to focus much on the autonomic neuropathy. So when you talk of autonomic neuropathy, which is the highest center in hypothalamus, which weighs actually just 4 grams. It is the size of your nail. It's located between optic chiasma and the brain stem. That gray strip area in the brain is called hypothalamus. It has got multiple systems. The anterior 2/3 part of the hypothalamus controls the parasympathetic system, and the posterior 1/3 controls the sympathetic system. That's how the sympathetic system or autonomic system, the headquarter, is in the hypothalamus. So we have the sympathetic system, which is fight or flight. We have parasympathetic, which is rest and digest. And then we have the enteric system, that's a new system, which is there in the entire GI tract. And all the symptom that you see in your patient depends upon where the disease is or where the location of disease is. And it contributes heavily to morbidity and mortality. Just to remind you, this is a very important subject to remember. And this association can be as high as 58%. So this is how you classify them as a cardiovascular, gastrointestinal, urogenital, and pseudomotor. Today we're going to limit our discussion on the gastrointestinal system, which is again various aspects like gastroparesis, enteropathy, and of course abdominal pain. Many of the patients with diabetes come to abdominal pain because the involvement of the visceral structure. You do their CT scans, you do the ultrasound, you do all the investigations, they are negative. This is because of the manifestation of the autonomic neuropathy these patients could be having. Now, how it's important to realize is that the GI tract is loaded with some of these specialized cells called enterographene cells, which are shown in the green line here. And what they do, they synthesize 5-hydroxytryptamine. And this is the highest concentration of 5-hydroxytryptamine in intestine, much more than the brain, just to remind you this. And how do they synthesize? By dietary tryptophan, which is essential amino acids, and a spore-producing bacteria called Clostridia. And when along with the short-chain fatty acids and secondary bile acids, you get the manufacturing of tryptophan, 5-hydroxytryptamine. And this becomes a neurotransmitter. Like I told you, that the brain also has neurotransmitter, even the GI system is neurotransmitter, and that transmits signal by the vagus nerve. Vagus nerve is like wandering nerve, so it takes the sensation to the brain, to the nucleus tractus salutaris, and from there the efferent starts, and the efferent system works on the acetylcholine receptors, which are called nicotinic receptors, and the most important function of the vagus nerve, somebody asked you a question, is to prevent inflammation. So anti-inflammatory activity of the vagus is very important, and that's what I've shown you on the right of your screen. You can see on the macrophage action of the vagus nerve reduces the inflammation, and therefore the patient gets a benefit as the anti-inflammatory property of this one. So if you look at the vagus nerve, 80% or 90% of vagus nerve is basically afferent. It takes all the signal to the brain. Only 10% of this vagus nerve is which is efferent. And that brings about the primary channel of communication between the GI tract and the brain. That's how the communication occurs. And therefore, after regulation of the autonomic system, the most important function I mentioned to you earlier is the anti-inflammatory property of the vagus nerve stimulation. Now what happens in gastroparesis? What happens in gastroparesis, interesting to remember, it's a left vagus nerve which supplies the entire GI tract, not the right. What happens right? We don't know much, but it's the left vagus nerve which does supply to the entire GI tract. And what is the function of this vagus nerve? Is the important thing is to accommodate the food inside, and after the food is accommodated, then starts peristalsis. And there are special cells which are called cells of Cajal, and these are the pacemakers of the stomach, and that's how they brings about propulsion of food ahead. And when you have the glycemic stress, oxidative stress, or decreased amount of nitric oxide, because there are some which are called non-adrenergic, non-cholinergic, means what? They work on nitric oxide, and therefore the depletion of nitric oxide is responsible for decrease in the distension of the stomach and decrease amount of peristalsis. Therefore, patient tends to accommodate food for longer time. Sometimes patient comes in and tells you, I ate 3 days ago idli sambar, whatever in the morning, that I vomited later. So that's how the gastroparesis patients manifest to you. And this is what you see on scintigraphy, which is the nuclear scan studying, which tells you that how much is the emptying delayed in patients who have gastroparesis. And if you have a 60% or more retention at the end of 2 hours and 10% or more retention at the end of 4 hours, that means this is the delayed gastric emptying, which is how you diagnose in a patient of gastroparesis in patients with diabetes. So let's look at this first patient. This 31-year-old female patient hospitalized with severe vomiting. She is again type 1 diabetics with 11 years history, and she had non-proliferative diabetic retinopathy, which was given the laser treatment. She has evidence of peripheral neuropathy. Her renal functions are normal. Her glucose control is optimized by giving adequate dose of insulin. Then despite the patient continued to vomit, the vomiting persisted. And for that we use multiple combination of drugs, like for example the dopamine antagonist, agonist and serotonin receptor antagonist, and antihistaminics were used in these patients, but patient did not respond. Eventually she was given intravenous drugs of this and patient finally responded. So 12% of your patients who present to you with this kinds of vomiting despite of controlling good sugar are because of gastroparesis, and conventional dose of insulin is recommended these patients, not the short acting analogs, because if you give short acting analogs patient will go into hypoglycemia because there's a delayed emptying of the stomach. So use conventional insulin rather than the analog insulin. There's one entity called postprandial hypotension. We heard of postprandial hyperglycemia. Is the entity called postprandial hypotension, which is a very peculiar entity which is much more common than the postural hypotension that you see in patients with diabetic autonomic disturbances. And this has got a higher mortality rate. But we don't diagnose it because we don't estimate blood pressure postprandially. We estimate sugar, but not the blood pressure. I recommend every one of you, at least when the patient complains of dizziness after eating food, instead of suspecting hypoglycemia, also suspect there's a postural hypotension in these patients. Common in both type 1 and type 2. It's a drop of 20 millimeters of mercury blood pressure after 2 hours after a meal, and of course it has got a multiple risk factors. The most important is splanchnic supply. Moment what happens is the patient eats food, there is a dilatation of splanchnic vessels, the sympathetic system fails here. Therefore there is no rear guard action of sympathetic system, and therefore the baroreceptors are weak, and therefore the blood pressure doesn't come up, and therefore these patients have a hypotension. The management of course requires multiple small meals. What simple clue is to give large amount of water to drink. If you drink large amount of water drink before the patient eats food, maybe this complication can be mitigated. There's a drug like carbose which can be used to prevent or delay the gastric emptying, and the short-acting GLP receptor agonist, which the previous speaker was talking, has also used in patients who have postprandial hypotension. So let's look at this second patient, this type 2 diabetic patient who came with chronic diarrhea and a fecal incontinence, which is well known in type 2 diabetic patients, fecal incontinence. There's a history of UTI in the past. She had tingling numbness and paresthesias. She has evidence of postural hypotension. She has a distal polyneuropathy in both lower limbs, and a rectal mucosa, anal sphincter was normal. She has uncontrolled diabetes with excess amount of excretion of protein in the urine, suggesting there's albuminuria, but a stool examination of fat content is 7 grams. It is normal. Anything above 7 grams means the patient has exocrine pancreatic deficiency. In those patients to diagnose celiac disease and so on and so forth. So therefore this patient has the evidence of gastroenteropathy of a diabetes management. The prevalences can be as low as 3.7 to 22%. Hydration is a very important thing in these patients. Rifaximin is a specific drug which can be used to treat patients of diarrhea of these patients. And remember that metformin can also contribute to diarrhea, and this is because of the decreased absorption of the bile acids by the peripheral intestine, the lower part of the intestine, and that contributes to these patients having diarrhea. And in the patients taking those non-sugar, sugar-free substances, especially containing sorbitol, these are the patients who also have these problems of diarrhea with metformin therapy. So this is in short the treatment of gastroenteropathy. Remind you that this treatment is entirely symptomatic, of course insisting on the fact that the patient should be controlled with diabetes and preferably use insulin therapy to control diabetes to this patient. Okay, after I have said this of the gastrointestinal manifestation, how do I connect to the brain? There's a bright idea of some of the researchers who thought when you want to link the brain with the intestine, you have to have some studies with that. And what they did was, they tried to stimulate the lower esophageal junction. They took patients of type 1 diabetes predominantly, and they did the clamp studies, the hypoglycemic clamp study they used to see that the glycemia is well controlled, and they looked at what happens in the brain. and they used EEG, either the evoked EEG or simple EEG, to find out the link between the GI system and the brain. And what they saw was, this is one study which looked at QST, the quantitative sensory testing in these patients, and the GI symptoms correlated the brain potentials in diabetic patients, and these results indicate the change in the peripheral visceral nerves as well as the central nervous system, linking thereby that there is a connection between the GI system and the brain, the brain to bowel, what GVK talks about. So the insular cortex is a specialized cortex which has the capacity to register the GI disturbance of the patient. This is also seen in patients with a post-ictal epilepsy who tend to vomit. And the focus, if you see EEG at that patient, if we do, the focus will be picked up at the insular region of the cortex. And therefore, it has been identified that insular cortex is affected in patients who have the gastrointestinal manifestation of a diabetic neuropathy of autonomic region. So therefore, the interpretation of these two trials, what it says is that diabetes patients with autonomic neuropathy and related GI symptoms show evoked brain potentials of a esophageal painful stimuli. This is what has been proven beyond doubt. And the last thing you can do is the imaging studies, which is called functional imaging or functional MRI. And the functional MRI also can pick up these lesions. And they looked at 26 patients of type 2 diabetes with 25 controls and showed that there are changes in the frontal and temporal cortex of these patients. And this is what you see when you look at the patients with diabetes. Without diabetes, you can see on the MRI, these are the changes which occurs in the insular region of the cortex, suggesting that's the focus of activity in the brain, which is responsible for the GI manifestation of this disease. So there are changes also seen on the histology, like periventricular nuclei changes, there are changes in insula, the visceral sensory processing is changed. All these have been documented on the histology, suggesting that the involvement of the brain is also part and parcel of the involvement of the GI tract. The cerebrovascular alteration is also important, especially shunting of the vein. Remember, there is a shunting of blood from the arteries directly to the venules and jumping the capillaries, and therefore the nerves are deprived of circulation of food or the blood. And these are the patients who can have the damage to the pericytes in the brain, which regulates the blood flow in the capillaries, and therefore they have thickened capillaries and decreased capillary density, are all shown, suggesting that also there's a vascular involvement as well, which links the peripheral system of a gastrointestinal tract along with brain. When you look at the management of these patients, of course the glycemic control is the most important thing. Prevention of hyperglycemia protects the autonomic system. And also using insulin has been shown to protect the brain, especially because the insulin is also produced in the brain. Interestingly, the brain also depends on its own insulin supply. And the peripheral insulin does also go to the brain. And this insulin has a protective action on the autonomic system, especially hypothalamus. The ketogenic diet, which contains only 75 grams of carbohydrate, is also proven to be useful in these patients, and calorie restriction, of course, is important. This diet increases the fat oxidation, therefore decreases the adipose tissue and reducing the inflammation, because the inflammation primarily stems from the adipose tissue. So therefore, if you can prevent the lipolysis, of course, if you can bring about the oxidation of fat, then you can have a better benefit effect. And of course, GLP is a very important drug. Talking about GLP, as I mentioned to you earlier, that these are the enteroendocrine cells of the GI tract, which, when they produce GLP, also goes to the NTS, that is nucleus tractus solitarius. It also has action receptors on the liver and pancreas, and it travels to the brain. And from the brain, the efferent comes from the vagus and acts on the stomach and on the liver. So this is important. That's how the GLP have a very important role in protecting the gastrointestinal system. And it does have the direct action on the brain, on the, as Dr. Sharma Velu was talking about in the morning, that he was saying he gave a lecture where the GLPs act on the hypothalamus and the nucleus tractus solitarius, and this actually is a neurotransmitter in the brain as well. So it has a beneficial action. Therefore, such patients, the GLP is useful. There's a vagus nerve stimulation is the technique also which can be used, either the implantable technique or you have the handheld device which can stimulate your vagus nerve, and this is useful in patients of depression for that matter. It's useful. It's also useful in post-traumatic syndrome of depression also, and it has been shown to be useful even in the inflammatory bowel disease and irritable bowel disease. What do you do yoga? Ultimately, or what is called Iyengar yoga, which is very precise, is the one which brings about stimulation of vagus. What you do is vagus. So the vagal stimulation, that's why decrease your heart rate and improve your vagal tone, and by that you improve the anti-inflammatory property of the vagus nerve. I think with that, I come to the last slide of conclusion. That diabetes patients with GI symptoms indicates the presence of structural and a functional brain damages. Changes in the insula seem to correlate with the GI symptoms, and a microstructural changes in the brain areas involved in the visceral sensory processing contributes to GI symptoms, and our future targets in the treatment of GI symptoms should be based on the modulation of the CNS reorganization. With that, I thank you very much for patiently listening.